Hello, and welcome to this webinar on multidisciplinary mental health care for adults with a recent ADHD diagnosis. We're talking about attention deficit hyperactivity disorder tonight. And a warm welcome to all of you who are watching us live, also to those of you who are watching us later on a recording. Before we start, I would like to acknowledge the traditional custodians of the lands across Australia upon which our panelists and our participants are located. And I'd like to pay our respects to their elders past, present, and emerging. My name is Mark Creamer. I'm a clinical psychologist and have a long background in working in both public and private sector mental health, as well as in academic and policy settings. But my specialty is actually mental health effects of trauma. And I have to be very honest and say that I don't know a great deal about ADHD. And so I'm looking forward enormously to being able to pick the brains of our expert panel tonight. I have to say, and I'm sure my panel would agree, that we're not pretending that we have all the answers to what is really a very complex and challenging area, but we will certainly do our best. And a reminder that there are a number of resources, tech support, other things on the website if you need it. But without further ado, let me introduce our panel. And a reminder that the panel biographies are all available on the website, so I'm going to keep it very, very brief. Dr. Naomi Rutten is a general practitioner and psychotherapist. She's president of the Australian Society for Psychological Medicine, and she's joining us tonight from South Australia. Welcome, Naomi.
Thank you, Mark.
I wonder if you could just give us a couple of sentences on your interest in PTSD. Not PTSD, sorry, that's my area. Sorry, ADHD.
That's fine, because it is my area of expertise. So GP, as you said, GP psychotherapist, and I specialise in developmental and complex trauma, but it really sort of started overflowing into complex behaviour disorders, which included lots of autism and ADHD. So became very interested in that. And then I do a lot of the pre-assessment and ongoing care and treatment, both medically and psychologically. I was diagnosed with ADHD 3 years ago, and I'm a mother of 2 children with ADHD. So 2 out of 3 of my kids have ADHD.
Thank you very much. It's very interesting. Now, just let me throw this one at you without warning. Do you think that having a diagnosis of ADHD helps or hinders in your role as a therapist?
So as a therapist and as a doctor, I think it helps because it allows you to have an understanding and an empathy that people who don't have ADHD can't have. They can have compassion, but they can't have that shared experience, that shared understanding. So my patients find it useful. I find it useful in regards to functioning. It is challenging.
Sure, I'm sure. And we'll learn more about that as we go through the night. Thanks very much, Naomi. Now, for our participants, for the purposes of the hypothetical, I'm going to be asking our panelists to take a particular role. And I need to emphasize that this may not be the role that they do in their normal jobs. It is, however, a hypothetical, and we'll jump in and out of it. And I'll ask people to take the hat off and put it back on again and so on. And indeed, perhaps put on different hats depending on how it evolves. So we will certainly draw on Naomi's enormous knowledge of ADHD during tonight. But for the purpose of our hypothetical, Naomi is going to be acting as a general practitioner in the community. Our second panelist tonight is Amanda Butt. Amanda is a mental health nurse practitioner joining us from New South Wales tonight, where she has established her own online mental health service. And as an aside, I have to congratulate Amanda on being recognised as the 2025 Australian Mental Health Nurse of the Year. Congratulations and welcome, Amanda.
Thank you so much, Mark. Lovely to be here.
And could I ask you also just to say a few words about your interest in ADHD?
Yeah, definitely stems from seeing how often it's missed. I see it in high-functioning women, in our prison population, leading to years of misdiagnosis, ineffective treatment, and preventable disease.
Right. Okay, good. Thank you for that. And we will draw on that as we go through. For the purposes of our hypothetical tonight, Amanda is going to take the role of a mental health nurse practitioner with expertise in ADHD, who acts as a consultant to an inpatient psychiatric ward. Um, our next guest is Dr. Karupia Jagadisan. He's a consultant psychiatrist in both public and private sector mental health facilities here in Melbourne, and he's joining us tonight actually live from India. He's kindly said that we can call him Jag, which is great, much easier for me. So welcome, Jag. Thanks for joining us. You're on mute at the moment. That's it.
Yeah, thank you, Mark. Can you hear me?
Yes, I can hear you. I can hear you perfectly. Thanks for joining us. And could you also just give us like a sentence or two about your interest in ADHD?
So I have been working in both public and private for a while, and in private there has been increasing need for assessment and support of individuals with ADHD, and I also realized there is a big gap in the public system. So that's an area of interest of mine, how to assess and allow people to get assessed at the public system. So I do sit as a chair for the ADHD network within the Royal College of Psychiatry, and so it helps to have a broader perspective on things and at the same time help with the certain processes. Thank you.
Excellent. Thanks, Jag. And for the purposes of our hypothetical tonight, Jag will be taking a role pretty close to his own as a psychiatrist in a community-based private practice. So we're a private practitioner. Our final panelist for this evening is Emma Ketley. Emma is a mental health occupational therapist. She's got experience in a variety of mental health settings, both in the UK and in Australia. And she's joining us tonight from WA. Welcome, Emma.
Hello from Wajak country. I'm delighted to be here.
Good. Well, it's lovely to have you. And as with the others, can I ask you about your interest in ADHD very briefly?
Yeah, I'm actually an ADHD coach and a mental health occupational therapist that works as a psychotherapist. And my background is working with borderline personality diagnosis in clients with emotional dysregulation. And around 2020, I realized just how many diagnoses of the mental health type were actually overshadowing the needs of people that had co-occurrence of ADHD. So around 2020 and 2021, I commenced ADHD coach training at ADCA, which is a flagship academy based over in America, but it was an online course. Yeah.
Fascinating. Okay, well, thank you very much, Emma. Thanks for joining us tonight. And for the purposes of tonight's hypothetical, Emma also will be taking a role very similar to the one she does. She will be working as a community-based occupational therapist and ADHD coach in a private practice setting in the community. So as you can see, we've got an outstanding bunch of experts in the area of ADHD today. So it's a very, very warm welcome to all of you. Tonight, we're going to work our way through a little case study, a hypothetical vignette. So in a minute, I'll introduce the vignette of Tanya, who's going to be our case for the webinar. And I'll ask each of our panel members in their allotted role to talk in turn about how they might assist Tanya as she negotiates her way through the system. We'll then open it up for a broader discussion about some of the issues raised by this case. And I do want to place a particular emphasis on the idea of multidisciplinary care. I actually hope that we will be able not only to talk about multidisciplinary care, but also to demonstrate a multidisciplinary approach in the way we manage the panel, by the way we interact with each other and we challenge each other and we support each other. So hopefully we'll be able to model it as well. But do remember, it is a hypothetical. People will come in and out of role as required. I'd also note that there are some different regulations and services in different states of Australia. And so we will try and draw attention to that where it's relevant. But now let me introduce our vignette. And if you wanted to just jot down some notes, please feel free to do so, because we're going to be coming back to Tanya a fair bit. Tanya is a 45-year-old woman. She's very high functioning. She's got a successful corporate career in high-level project management. She's been married for 15 years to Greg. Greg is the primary carer at home. He also works part-time as a bookkeeper. And they have two children, Damien, who's 13, and Jacinta, who's 11. Tanya has a history of some kind of unspecified anxiety, probably generalized anxiety disorder or something similar. But she's never had a formal diagnosis. And the only treatment she's had is some medication. She's been given a low-dose SSRI, sertraline, which she continues to take. So, Naomi, let me bring you in. Tanya has been a long-term patient at your practice, but she's a very irregular attender. You don't know her very well. But she turns up in your consulting room telling you that she's been struggling for some months now. And it turns out that the precipitant seems to have been an incident where her 13-year-old son nearly got expelled from school. That seems to have settled down, but she says that since then, she really has not been coping very well. And again, our participants may wish to jot down some of these notes. Indeed, our panelists might as well, actually. She tells you, Naomi, that she is very much more restless and distracted than usual. She can't concentrate even on simple tasks. She finds herself making many mistakes. She's losing things. She's forgetting things, forgetting appointments and so on. And all of this is extremely distressing for her because she did feel in control before. Her relationship with Greg, her husband, is very strained. He complains that she doesn't listen to him, that she looks zoned out half the time. Her anxiety has worsened, her self-esteem has plummeted, and basically she feels overwhelmed and doesn't think she can face going back to work. So Naomi, as a busy generalist GP, you're seeing Naomi in your practice. What are your first steps?
So I think a lot of GPs, that are watching it will feel similar. The first thing is always to really gather that history about, what the concerning symptoms are for her, how long they've been going on for, and then in what way they're affecting her function. So I'd spend a bit of time with her, assuming the first appointment, that she's come to is a 15-minute appointment, getting a bit of an idea of how's your sleep, how's things within, you mentioned the relationships, that sort of stuff, but sort of, appetite, exercise, going through those lifestyle measures, how are they affecting her? Because we'd only have 15 minutes, I'd probably start by going, thinking things like perimenopause, having in the back of your head, it's much rarer for that age group, but always thinking memory problems or conditions that are related to memory problems. So I'd probably organise a blood test for her to check her iron levels, vitamin D levels, base bloods of, hematology and electrolytes, doing a broad scope to sort of really get a picture of what's going on, make sure that we're not missing anything untoward. Again, examination-wise, how is she appearing? Is she looking pale? Is there evidence of a physiological condition that might be contributing to her symptoms? And looking at those as we then, and then what I would then be doing while she gets the blood is booking probably at least two more 30-minute appointments where you can really sit down and go through things, get a further history of what's going on, how long it's been happening, and make sure you're pulling apart what the underlying causes might be, one of which could be ADHD, which, of course, the symptoms worsen with perimenopause. So really looking at perimenopausal symptoms that might be overlapping at the time as well.
Good. Okay. Well, you do make another appointment with her for the following week. But at this stage, are you thinking at all about involving anybody else?
At this stage, depending on her function. So if she was saying that she can't get to work, she's so stressed, she can't function, she can't work, we might be sort of sitting there, I might be thinking, well, do we need to bring in sort of psychological supports, counselling supports or things like that? A lot of GPs are trained in focused psychological services, so may feel comfortable to do bits and pieces of that themselves. But if they aren't, they may refer sort of outward in that regard as well.
Are you going to be able to find someone to refer her to?
Where I am, the wait list would be 9 to 12 months. So I might find a counsellor, but personally, I would be waiting to see what the underlying cause is and really nutting out what the cause is before I refer, because even different counsellors, different psychologists, therapists will have different areas of expertise. So I really want to make sure I know what area to target before I go into that. So
Fair enough too. Okay, just briefly, can I ask you to take your hypothetical hat off for a minute and say, what do you think, the other things that you think a generalist GP who doesn't know much about ADHD, what might they miss in a scenario like this?
One of the things that could be easily missed is an assumption 45, high stress job, and an assumption that it's perimenopause and her anxiety. It might be chronic high level work and therefore burnout, and sort of bundling it up into those things, and actually missing that cognitive impairment that she's got. Like, yes, we need to make sure, is the cognitive impairment from the anxiety and depression, or is the anxiety and depression secondary to the fact that there's a neurodevelopmental condition that is causing it to be much more difficult to function?
Yeah, good. Okay. And anyway, look, who knows? It may well settle. She's had a chance to talk to you. She's feeling supported, so it might well settle. You've got an appointment with her for the following week. Alas, the following day, you get a call from her husband, Greg, to say that Tanya has admitted herself to a private psychiatric facility. They have very high-level private health insurance, this family. So she's admitted herself voluntarily to this private psych hospital. She's saying that she can't cope. So the ward nurse who admits her, Amanda, is aware of your expertise, not quite sure what to do. She gives you a ring. What are your first steps in this situation?
So she's come in to see me. Sorry, you're saying Naomi's called me, or the patient's with me now?
The nurse on the ward of the inpatient unit. And she says, look, I don't know quite what to do with this, but we do have this expert mental health nurse practitioner. I'll give her a ring and say, what should I do with this patient? What have you got any ideas you could advise this ward nurse, the staff on the psychiatric unit?
Yeah, absolutely. So the first thing I teach my students and my mentees is, and it's the foundation of my own practice, is your therapeutic relationship. So that comes before anything. So you'd want them to develop that rapport, create emotional safety, and provide a trauma-informed space. So just making sure she's safe. You're doing a risk assessment, containing that, ensuring that she's, not suicidal, that she's okay for the time being. And then we start to involve, family and explore her immediate supports to see what the presentation is about.
And would you talk to Naomi?
I would love to, yes. I would waltz right in there and do the assessment myself if I could. But yes, firstly, if she's building that rapport, we want her to be able to build that rapport with whoever she's going to spend the most time with.
Given what I was going to say we know about Tanya, but we don't, but we might suspect strongly. Do you think that she would need special assistance in transitioning to a new environment?
Yeah, absolutely. So change would be something quite difficult for someone like Tanya, because she's got everything usually under control, and then things started to unravel. So a new environment would be quite, scary for her. And this is why we would engage family and any immediate supports to ease her in and ensure that she's got the right environment and supports, and also asking them questions, because she may not be in the right frame of mind to be answering questions about risk and safety and her type of presentation and why she's presented herself.
Good. I'd like to come back to risk in a minute. But given that it's not a specialist ADHD clinic or anything like that, what do you think might be reasonable goals for a brief admission to a private psychiatric ward in this case? What might they hope to achieve with someone like Tanya?
So stabilizing her functioning, ensuring that she's able to do her everyday tasks, activities of daily living. Is she able to shower? Is she able to, get her meals ready? So ensuring that she's got some level of functioning to be able to be discharged. The other thing is risk and safety. Is she safe enough to be discharged? Is she going to hurt herself? Or is she at this point where, you said she was distressed? What level of distress is that? And to what extent has she thought about that distress? So ensuring she's got, that scaffolding around her to ensure that she doesn't fall back down again, creating like a crisis management plan, distraction techniques, all that sort of thing. But to ensure that she's that level anxiety isn't too high, we need to look at that SSRI. And it might just be a temporary thing before we then find out she does have ADHD and explore that diagnosis in more detail. She may need that dose of SSRI looked at a little bit, just as a temporary measure to help her through the anxiety and get her through that admission.
Super. Okay. Well, we've got the ideal person to consider that medication. So after about 5 days, she does stabilize and she does feel a lot better. You've done your risk assessment and you don't feel that she is a risk to herself or to the family or to others. So she's stabilized and she's now ready to be discharged into the care of a psychiatrist in the community. Given your contact with her, Amanda, will you just be available to stay in contact if she wants it?
Absolutely. You can create a proper discharge plan, having all those supports there, people she's able to contact. It's a private facility, so you'd definitely be available for someone like that. Again, ensuring that you have all of the supports available. Okay,
thank you. So, Jag, you've received a referral from Naomi and also a discharge summary from Amanda and the ward. Given what you know so far, what would be your first steps when Tanya comes to see you?
Thank you, Mark. I think it seems like a lot of good work has been already done. So the first psychiatric assessment is a very broad and general approach in general. So what I would be interested in knowing is that a high-functioning individual is suddenly losing the plot for an apparent reason of her son is struggling in a way. So it's very important to understand what some of the factors are leading up to this level of, dysfunction or suddenly losing control. So I will be working through the symptom clusters to see what could be playing a role and also to explore some of the dynamic factors. As you have alluded that there is a history of anxiety disorder, so it may be asking more questions to characterize it, and whether it's a generalized anxiety, which often can coexist with people with the neurodevelopmental disorders, or is it an anxiety part of a personality structure like a cluster C or perfectionism, which often exists in neurodevelopmental scenarios. And I'm looking into any trauma history, post-traumatic stress disorder, or anything like an obsessive compulsive disorder. So having a broader approach to the anxiety to characterize. The second thing is whether the anxiety is leading to what we call it like a secondary depression, which is emerging like a major depression, which is flaring the risk side as well as functional impact. And that will help us to plan management, obviously. And even though she is feeling better, she is out of the hospital system, at least good to know whether she had any similar pre-existing flare-up of a depression, whether it's a part of a reoccurring depression or is it a low-grade persistent dysthymia, which has just flared up because of the stressful situation. And the third is to explore, as I mentioned, a bit more about her nature. So a project manager who generally tends to have a lot of structure and routine and to clarify any personality aspects that may be playing a role other than just perfectionism. Is there any element of, say, cluster B or cluster C and characterize it? And what some of the strategies Tanya would be playing to cope so far, whether it's mainly like routines like physical exercise or any sort of recreational activities or any sort of alcohol use which is hidden and which is playing underlying, or any sort of misuse of benzodiazepine or things like that, or over-the-counter products which may be used to alleviate anxiety, which often happens in high-functioning individuals. They don't use many other substances. They usually use substances that can be easily available, not seen very bad to other people. Then to clarify how long these anxiety disorders and to explore developmental history and to look into, generally it takes a session or two, depending upon the cues, what we get from the clinical history. If there is a general struggle, as you say, with concentration, listlessness, zoned out, these are very typical terms we often hear these days in ADHD scenario. And often I have seen that women present very late in the life and they can mask it very much as well. So exploring neurodevelopmental history, both ADHD as well as autism and and also look for any family history which may be indicative of genetic factors playing as well. As earlier mentioned, so it seems like a medical history has been ruled out, but I would be still keen to look into any sort of underlying thyroid disorders which may be playing a role or which has come a little bit more prominent now, making the anxiety worse. And lastly, about psychosocial factors. Son is having a big problem, and why Tanya is giving up now. So to look for son's behaviors might give a clue about both neurodevelopmental as well as trauma. We know there are times there is a transgenerational trauma happens when there are neurodevelopmental disorders like ADHD running in the family, not in a full syndrome level, at a trait level, and members can communicate very intensively that can create micro trauma. So we're exploring that. And lastly, relationship with her husband.
Yeah.
Whether he was compensating or whether it's falling apart somewhere or she had enough with some sort of a problem. So having a very holistic approach and trying to figure out what really broke the back of the camel now. Why? So that's what I will be more interested in the first assessment. And if Tanya is settled enough, I wouldn't be making a huge change with the dose of the SSRI, but I would like to make sure it's sufficient. Like if it is a low dose, if she's only on say 50, it didn't stop her having an episode. So certainly I will up the dose to the next level, which will be close to maybe 100. We know it can go much higher. And certainly I will emphasize the need for psychological interventions and make sure that she is able to apply some of those strategies to deal with problems. So excellent. That's how I formulate the first one. Yeah.
Yeah, excellent. Okay. So, I mean, you've raised a load of points there that I will come back to because I think they're really important, but I just highlight the fact, the sort of a comment that both Naomi and you made that of course, there are a number of potential diagnoses here, and we really need to do a very thorough assessment before we jump into any definitive diagnosis. But having done your thorough assessment, you do think that there's a pretty good chance that she does have ADHD, adult onset ADHD, and we'll come back to that in a minute. But you decide that she needs a bit more support than you can offer. Actually, just quickly, how often would you hope to see Tanya? Given your private practice, how busy you are, how often might you see her?
I think that varies depending upon how the situation is. So it could be weekly, initially for first next appointment in a week, then fortnightly to monthly. And so basically depending on what other supports Tanya is having. Okay. If Tanya is already linked up with some supports in the community through the counselor and they can offer some space to reflect, then my session is slightly after a gap.
Yeah, just okay. Point taken, but you would try and see her fairly often, at least initially. Okay, so you decide that she needs more than you're able to offer, or you think that she would benefit. You talked about psychosocial support and so on. And so you contact Emma. Now, for our purposes, Emma, as we said, you're working as an OT, mental health OT, and ADHD coach in private practice. You've been provided with a referral letter from JAG. You've also got background stuff from Naomi and from Amanda. Let me start with your role as an OT. Just very briefly, what do you think you might be able to offer Tanya in your role as an occupational therapist?
Okay, so occupational therapists work with people through a functional lens, enabling people to participate in meaningful activities that they want and they need to do. So there are so many Tanyas around at the moment where they have been doing so well for so long, and then all of a sudden there's an impact on functioning. So the first thing that I would do as an occupational therapist is, as Amanda mentioned, there was probably some assessments in the ward, on the ward. So I would reach out to see if there was any OT assessments. I would probably then also want to really flesh out and explore, like the team are, around what's actually sitting in line with an ADHD assessment. So as we know, the criteria for ADHD assessment is that it's showing up in more than one or more settings. So OTs look at occupational performance across productivity. So what's her performance like at work, her self-care, and also her leisure activities and whether there's any occupational imbalance there. And how I would probably frame that is using a tool that I personally like, which is a model of human occupation tool, which is No Cares, which is a performance self-assessment for Tanya to complete.
Okay.
We would look at, there's obviously a number of situational stresses. Her son, with the school situation, as we know, ADHD has got around a 70% heritability. So it's possible that we haven't got a diagnosis for Tanya yet, but that's also running in her family and it's intergenerational. So I might ask her about her mother, like some other members of the panel have said. And obviously she's on a medication for anxiety, sertraline, and there's some issues with her husband. So sertraline would have an impact on intimacy. There's a lot of sexual dysfunction side effects that can come alongside that medication. So I would probably ask her, as an activity of daily living, those questions around what is her roles and responsibilities, is she comfortable, and is there any kind of barriers to her participating? And that would be my start point.
And so, yeah, and on the basis of that functional assessment, largely, that will dictate a whole range of potential interventions. Can you just, because time is going on, but I am fascinated in this idea of an ADHD coach. Can you just give us a quick summary of what it is, or what you might offer Tanya if she decides to take that up?
Okay, so in this situation, just to be quite clear, if there was any ongoing stress, if there was any risk or mental health distress, I work both as an ADHD coach and as an occupational therapist. I would probably point her towards occupational therapy support or psychotherapy support, so we can look at the mental health distress. If, however, that is stabilized and she feels that she just wants to really understand this new diagnosis, which might be ADHD, then an ADHD coach partners with someone. So we partner, we're very much client driven. There doesn't need to be a referral. The goals are set by the client, and it's very much more a reflective, future focused role, looking at helping Tanya understand her new self, discovering her strengths and building on her future roles and aspirations.
I'm sure that you could say, how long's a piece of string, but what might be a rough idea of how much time you might spend with your client if you were the coach?
With
daily
coaching,
contact, for example?
Yeah, I think with coaching, because it's very much client driven, rather than symptom reduction or stabilizing or capacity building, which is more occupational therapy. With coaching, I might get to a point where Tanya feels that everything has settled down, and I could work with her for up to a year, but that might be there's a maintenance check-in monthly if I was ADHD coaching. Okay,
yeah. Lovely. All right. There's a whole lot more I'd like to ask about that, but I've got a massive clock sitting here and it's telling me time's moving on, Mark. Get moving. Okay.
There's so much more I could say.
Sure there is. Well, I'm sure there's a lot more that all of you could say, and I'm absolutely confident about that. So I guess what we could say is that we now have our multidisciplinary team around Tanya. So we have support as needed from her GP, Naomi, and from Amanda, mental health nurse practitioner. We've got a psychiatrist who's seeing her every couple of weeks or whatever as required. And we've got Emma providing some OT and some possibly ADHD coach support. So she's in a good place, and we are now ideally a team that are going to work together. And that, I think, is the challenge. And I'm going to come back in a minute and talk more about how we might do that as a multidisciplinary team. But I do just want to, because I think it is an important question. We've kind of alluded to diagnosis all the way through, but let's put it on the table and talk about diagnosis of ADHD. I mean, we can look up the DSM criteria, and I think we should. You all know it, but those of us who don't know it, we should have a look at it. What do you think? Are the DSM criteria good? Do they capture the essence of this condition? And I'm happy for anyone to jump in, although. Oh, nobody wants to. Yeah, go on then, Emma.
So her criteria, the diagnosis could be covered under a lot of the inattentive DSM symptoms for ADHD. But in looking at whether DSM really reflects client experience, they don't mention emotional dysregulation. Emotional dysregulation is not reflected in the DSM criteria for ADHD. And anecdotally, as a lived experience person with ADHD, it is very much a marker of ADHD.
But we do have, I don't know the criteria, so forgive me, but we do have the inattentive, but we also have impulsive. Does that, I mean, I guess, are those subtypes valuable? I might bring you in, Jag. What do you think? Are they useful subtypes or useful? I'll come back to you, Emma, because you want to say something more. But let's just give Jag a second, yeah?
Yeah, so thank you, Max. So what Emma says is true. A DSM, I think it has evolved over a period of time, but still has issues and limitations. And it focuses typically on, let's say, young boys. That's a prototypical picture it's trying to portray. That's where the problem where it doesn't capture the experience of particularly women in general, and that's where the emotional dysregulation aspect is left out. And also there is the limitation that it doesn't capture more of the cognitive disorganization, which is an underlying core thing. It looks for more markers of those disorganization than actually pinpointing a disorganization is the main thing. So there are limitations to DSM, but even though it's widely accepted as a diagnostic tool, and ICD is not too far from DSM in that sense.
Okay.
And
yeah, I mean, I'm interested in your comment there about how perhaps it doesn't reflect very well the person that we're talking about, so an adult female kind of thing. You're nodding, Naomi. Do you want to add to? I mean, I guess the question is, how likely is it that Tanya would have actually been diagnosed with ADHD, given what Jag's saying? You know, young boys, not that bad.
It's really, really variable depending on what history is taken, what investigations, but also what focus, but also what. So one of the things that I think all of us would have done is sort of, what is it that she wants to work on? So, you know, she may be like, no, I don't believe in ADHD. I don't believe in those things. Or, you know, there might be cultural or religious, you know, there's all sorts of things that might mean that for her, you wouldn't even broach the idea of it. So it, depending on which doctor, which therapist, which support people she had, it could be missed, especially in females. And especially as Jag and Emma were saying, and I think Amanda would agree, like the DSM-5 does miss those elements, and also the masking, especially of women, that they have to do. So, you know, I do have a good friend, and she and I sort of wrote our own assessment criteria. It's sort of like, you know, how long is the smell test of a load of washing? Like, how often are you putting a load of washing on and forgetting and then sniffing it? Is it okay because you forgot? Things, you know, functional things that we all do for those of us that have ADHD. So.
Am I right in saying, I've got this vague memory from when I did know a little bit, does it have to be childhood onset? Do we have to say this person has had these problems all their lives?
My understanding is it can show up in adulthood. Personally, I think it's probably always been there, but they've masked and coped and had coping skills throughout that have sort of managed things. I think during adolescence, because of that change in function during adolescence, there'll often be significant worsening of symptoms, but it doesn't mean they can't mask. Or I often find, especially those that don't have so much of the hyperactivity and more of the inattentive through school, because they're dissociating and they're quiet, they don't get seen. Especially girls, they're just, no, there's nothing wrong with them. They've been quiet. They're not a hassle. You know, ADHD are busy, noisy people. Not everybody. One of my sons has ADD over, you know, doesn't necessarily have the hyperactivity. So I think it can very, very easily be missed and masked, and they have their coping strategies, and therefore it shows up in adulthood. But personally, I think it's probably always been there.
Yeah, sure.
Mark, I see this a lot in my practice as well, because I do diagnose ADHD, but I see that in childhood, it was there, but they they were masking it in a way that, they had a lot of structure. Their parents were quite strict, so they had to abide by certain things, otherwise there'd be consequences. So they weren't able to forget anything, or they weren't able to lose any of their belongings, so they'd get in big trouble. And then also the competitive sports. If they were doing any competitive sports throughout their schooling years, or if they were doing scouts, so again, regime, routine, they could mask throughout their entire childhood and adolescence years. And then when they stop doing all of that, that's when it starts to rear its ugly head.
Yeah, quite. We should just touch on it. And since you were talking, Amanda, we've heard a bit of stuff on the news about New South Wales recently expanding the kind of, I think, to GPs, saying that GPs can diagnose. Whatever that means. I still don't quite know what that means, because you say you would make a diagnosis. I expect Emma would, and Naomi, whatever. But that's correct, is it? And do you think that's a good thing that we've expanded? It probably means that. Sorry, does it mean you can make a diagnosis in order to prescribe a stimulant? Is that what it's about?
Yeah, I think Naomi could answer more about if they're able to prescribe under this new legislation.
Yeah, so I think, and I'd have to look carefully because I'm in South Australia, but it was for GPs who have done extra training, and it's going to be limited to a certain number of GPs. They can do a diagnosis, and I agree with Amanda and Emma and Jag. Like, we can all diagnose it. We know we have the tools and the skills and the knowledge to diagnose it. It doesn't mean it's accepted by other places or professionals, and it also doesn't mean that we can initiate prescribing of stimulant medications.
Sure.
What they're doing in New South Wales is that a certain number of GPs who have done extra training will then be allowed to assess, diagnose, and initiate medication, sort of bridging that gap.
Yeah, sure. According to my research, GPs with specialist training can do it in WA, Queensland, and now New South Wales. So it's still many states where we are relying on probably a fairly long wait to see a psychiatrist in many cases. However, I'd like to just get you now to put a different hypothetical hat on, although it won't affect you too much, Naomi. But Tanya had plenty of money. She had a very high level private health insurance and so on. How would things be different? How would her path through the system be different if she came from low SES group? She didn't have any health insurance. She had to go through the public sector. And let's quickly just take it through your areas. So in terms of the GP, would that make much difference?
Yeah. Where I am, there are a few in the public system. There are psychiatrists that will do a private clinic attached to it. The waiting list for those is over 12 months. And, it can be a little bit hit and miss of who they're seeing and when and things like that. The other, if I referred privately, it's usually anywhere from $1,400 to $1,800, and the reality is I've got numerous patients who just simply can't afford a diagnosis, so that they can get the treatment that we know they need, so that they don't die younger.
It's an irony, isn't it? It's absolute irony. Amanda, I know you don't see yourself as an expert in inpatient care, but nevertheless, can we just chat briefly about if she needed an admission and she was admitted to a public psychiatric facility? And I'll get Jag to comment on this as well in a minute. Would she have had different care? Would she have been able to get in?
It's unlikely that she would get in at this stage. There was no overarching, suicidal ideation or suicidal plans. There was no psychotic symptoms. It was just that she's not able to function. And so that wouldn't be on a high priority list to be admitted in a public health system at this stage.
Would you go along with that, Jag? It'd be hard to get her into a public sector facility.
Yes, absolutely true. That's a reality of it. And the maximum would be that Tanya gets attended by a crisis team, and the crisis team functions differently, and the threshold for allowing somebody to access inpatient care is different. It's mainly risk-driven, and very rarely we see admissions for diagnostic purposes. That used to be much before, but not anymore. So there is a real barrier. But this is one of the areas the Senate inquiry also highlighted, that there is a huge gap in the public system supporting this access for ADHD care. So hopefully we see some changes eventually, but at the moment there is a big barrier.
And Mark, I just want to add in there too, like even if you know, so if she sort of turned up to the public system and that sort of stuff, even if they referred her to a community mental health team, it's unlikely, given her symptoms, that the community mental health team are going to see her as well. So the reality is that her first point of call would be either someone like Amanda or the regular GP managing things, and utilising people like Emma, psychologists, counsellors, other therapists and stuff as well.
Well, can you see her, Emma, if you're not going to get paid? Well, sorry, if she's not going through the private system, can you see her through the public system?
How I work right now in my own private practice, I don't in-reach so much. No, not, you know, I suppose there is that, obviously, the private practice model that I follow. But just coming on board with what you said earlier, sadly, this is what I believe was happening to a lot of my clients that were diagnosed with borderline personality disorder. Because if you follow Tanya's trajectory, if she continues to decompensate, her relationship suffers, situations will remain unresolved. This is where she will be going into decompensation and crisis. And this is where she's highly likely, the other diagnosis, borderline personality, anxiety, depression, suicidality, that is what's going to get her noticed and entered into the public mental health system.
It is a bit tragic that it has to get to that point, isn't it? When it could be stopped before. But that's the world that we work in. Let's talk a little bit, if we could, about multidisciplinary care and whether we keep her in the private sector or the public sector or a mix of the two. We've got the four of you as part of her multidisciplinary team. What in an ideal world, what would it look like? What would multidisciplinary care for Tanya look like? Does anyone want to have a stab at painting a picture for me?
In my role now as a mental health nurse practitioner in private practice, I do bulk bill unlimited sessions for mental health care. So I would be seeing Tanya in this case as many times as she wanted. It'd be all bulk billed, but I'd then in reach to Jag as a psychiatrist to kind of set up the medication regime. I'd then tap into Naomi's services and hope that she could continue prescribing a stimulant if it is, or I could prescribe the non-stimulant, and we'd all work together in that sense. I'd probably be able to see her more frequently because of being bulk billed, and then maybe Jag would see her every few months, and Naomi would continue to look after physical health and bloods, etc.
Good. Bearing in mind we are still talking about the ideal world, so that sounds good in the ideal world. Emma, yeah?
Yeah, I mean, some other points of funding are the better access to mental health scheme. So, that's what Amanda was talking about when she was talking about the bulk billing. The Medicare rebates are available for up to 10 sessions for psychotherapy with Medicare endorsed professionals. And if everything was stabilized, there's also funding available to offset the cost of ADHD coaching. As Tanya is working, she actually can have access to job access funding, which will give her about $1,600 a year to be able to use that to help manage ADHD and the symptoms.
Well, that's good. It's not a huge amount of money for a whole year, but still something, isn't it? But let's not go. Let's come back onto the idea of how's the team working together. So Amanda presented quite a nice picture there, I think. How realistic is that, do you think? How often? And what would you need? You'd need a regular case conference, wouldn't you? You need to be chatting to the whole team every 3 or 4 months and just say how you're going and what you're doing.
It really depends on, I mean, that kind of depends on how the patient's going. So I think all of us really, even though we may not be in the same building, we all work in multidisciplinary ways. So I just, had a letter from a pediatrician asking me to take on care of a patient that I've never seen before. And, then I might see them manage the medication, refer back to the ped if need be, and then, intersperse letters in between times, utilise whether it's an OT for this person or a counsellor or a psychologist or somebody else. And so you don't necessarily have to have formal case conferences because you're sending letters to each other and updating each other in between, especially if they're stable. So we already work in multidisciplinary teams. It just doesn't look like let's meet once every we can sit down and discuss all the common clients of working in one central place.
Do you think, Jag, is it easier to do the kind of things that we're talking about? And I take Naomi's point that it doesn't have to be actually talking that often, but do you think it's easier to do that in the public system than it is in the private, or vice versa even?
Public system is easier because there is a system of like a case manager, and there are case managers with certain disciplines, and we have peer support, like a lived experience workforce, and we have junior staff. So there are systems which can be easily replicated, how we manage with the chronic illnesses, similar model. But the awareness and skills to manage ADHD is very low. So that's where the gap is at the moment. Private, I agree with what Naomi is saying, and Amanda is highlighting as well. In an ideal world, if you take it as an ideal world, first of all, there is no model which has been tested out properly to see how to care. But in an ideal world, certainly it would be good to have, practically speaking, we do send letters and try to communicate because that's what probably time we have. But there is a change in Medicare as well, that they are probably already implemented an item for a case conference, which allows other practitioners to come along and have a chat. May not be for Tanya, maybe other complex patients. It would be a good space to use because sometimes you hear from clients saying that there is a gap in communication between different practitioners. So having a complex ADHD comes along with a number of other conditions. So when somebody is more complex, having a conversation through a case conference even once a year or once in 6 months will be a lot more easier to have a shared understanding and goals.
Absolutely.
That's an ideal. Yeah.
And what do you think gets in the way? Why? I mean, my experience in mental health was that didn't happen very often, to be quite honest. People did tend to work away on their own, and there might be the occasional letter, as you say, Naomi, but there wasn't a great deal of communication. And I'm just wondering what gets in the way. I suppose the obvious thing is time and so on.
Yeah, the time, a lot of the time private, like we all work in different hours, after hours. So that's a one problem. And also lack of incentives from funding aspect as well to do this sort of a case conference. And when people are very busy, there is no incentive. That's not helpful as well. So I think both time, resource availability, as well as incentives all need to be aligned. Yeah. And also it's a habit. I think it's a new. It's also a new thing for the system. If we all do it, say next 12 months, there is a constant push to develop this sort of a case conference model once in 6 months for certain patients. Probably it will become easier for us to do eventually.
Yeah, absolutely. Naomi,
Yeah, sorry, Jack. It's one of those things. So GP for case consultation, GPs, there's very strict funding rules for it. And so often if it's something where there has to be a certain number of doctors or professionals that are attending or things like that to be eligible for the rebate. So often it's a financial thing as well as a time thing. And I think all of us, we're just so overwhelmed with the amount of patients that we're trying to see. So it's that real mix of we're kind of chasing our tails and we end up writing letters, but it's often in our spare time, and therefore we don't earn any money whilst we're doing it, and it's time that we're away from our own families and our own lives.
Okay. I certainly agree, Naomi.
Okay. But at least we're agreed on what the ideal looks like, and if we can get closer to that, the better. Has anybody got any hints for our participants out there in the real world how they might be able to do this a bit better? Is there? Let me ask you, Jag, because, well, actually, and you, Naomi, I think there are some clinicians who are a bit frightened of ringing up the GP or the psychiatrist because we know they're really busy and the secretary won't let you through and all that kind of stuff. Do you think they should persevere?
It depends.
Yes, I think so. Sorry, yes. Go on, please. Sorry.
Jag. From the GP side of things, like you can continue to, but again, trying to grab hold of the psychiatrist who is super busy, and then when they call, we're super busy, and it can be difficult. There is sort of online psychiatry number that GPs can call to ask questions and advice around that. You know, trying to keep on top of what services are around you and available to you, so that you know who to call and who's sort of going to be able to be part of the team for your patient. And I suppose for a lot of areas and people who can access telehealth, that can often be, you know, a bit wider, and there's more opportunities for things that way. So
okay. Again, time's going on. We could easily spend the whole webinar talking about treatment, but I would just like to explore what the various components of treatment might be. And perhaps if I could talk to you first, Jag, and perhaps Naomi, about medication, because that's what we think of first. We tend to think of stimulants, psychostimulants, Ritalin or whatever. Is that reasonable? Is that likely to be the first line of treatment? Or indeed a different medication?
Yeah, so I tend to, even before I've done or referred for the assessment, I'll ask the patient, do they want a diagnosis, or do they want, you know, to consider stimulants? If they don't want to consider stimulants, you know, I'll diagnose and we'll manage, you know, all the other ways. And lots of education around the purpose of the stimulants. It's there to help make things, the function easier, but it's not going to fix the ADHD. So stimulants are often the first line, but the reality is not everybody's going to respond well to them. It's complex accessing them. A lot of, you know, some GPs don't want to do the prescribing. Again, it's more of a process. So each state's slightly different. For me, I have to then lodge an application online through Script Check SA to get approval for ongoing prescribing. That takes time. Then it can take anywhere from 2 to 3 months to get approval to then prescribe. So in amongst all that, you're then considering, well, let's look at the lifestyle factors. Let's look at the, you know, behavioural things that we can change as well.
Yeah, absolutely. Jag, can I just bring you in to pick up on Naomi's point? If we decide against stimulants, are there other medications that would routinely be used? I've heard of clonidine being used, for example, but any other medications that would often be used in ADHD apart from the stimulants?
So non-stimulants, they are not a bad, obviously they are not bad compared to stimulants. Stimulants they have a very high margin of success. So the effect size is close to, I think, 80%. It's one of the highest what we see in medicine in general.
Oh, really?
Very high.
Wow.
Very
okay.
high. So it does work, but what happens? They are very short-acting medication. Even if you have a long-acting version, still they don't persist for 24/7. So that's the limitation of stimulant therapy. It may help the person to work through the daytime. What happens afterwards is the problem. And there's a tolerance issue. So non-stimulants, I find it particularly if they can be waiting, even though they are second line, there are criteria why we go for non-stimulant. But if they have coexisting anxiety disorders, depression, they can wait. Then non-stimulants like atomoxetine, which is an antidepressant, it's not a bad option. Once it works throughout the day and night. So it's much more stabilizing. So what we also need to realize is that not everybody, I have seen what Naomi says, there are times people just want the diagnosis to have a closure of, maybe to have an understanding of their life story. I have seen people didn't want to take any medication. They're happy with how they are, and they just want to work on few psychological tools, and they don't want to see me anymore. So we have to realize that individual goals are very important. Unless they're really struggling day-to-day functioning wise, we don't necessarily need to go for a full medication option. But if they have tried everything, then certainly there's a medication option to consider.
Yeah, okay. Can I ask Emma and Amanda to come in then? And Naomi's already alluded to a lot of things, and you have earlier in your talks as well. What would you see, just very briefly, as being the primary components of intervention for, let's assume that we have made a diagnosis of ADHD with Tanya. What would you see as being the most valuable, the kind of really high impact interventions apart from the medication? Either of you.
Amanda, do you want to
You go first.
So we're talking about a late diagnosis case of someone that has spent their life in an executive role. And so a late diagnosis at this point is really impactful in the framework of all of a sudden questioning your self-identity. There's actually a lot of grieving that can happen in late diagnosis. So there's probably a space here for self-compassionate understanding around what the diagnosis means for them and what it will mean for in the future. It's also been alluded to by members of the team already that the medication will just help improve her focus. For Tanya, it's actually the pills won't teach any skills. So if anything, it will give her the ability to focus more, and that sometimes amplifies the anxiety and depression already in this context of ambiguous loss and grief. So the work for an OT here would be around really what transferable skill sets has she got, what strengths has she got to really perform functionally those tasks that are so important for her. So there might be some executive functioning scaffolding. And for the coaching, it might actually be questioning around, with this new version of yourself, what do you want to do?
I think it's a very important point. Of course, that's your specialty. I do think that certainly in my training, we barely mentioned functional outcomes. Our job was to get symptoms down. And yet, this functional stuff is I think, so important. Amanda, is there anything you would like to add very briefly? Because I want to move on to something else.
Yes, just the same as what Emma would do in terms of trying to find out what the person wants to do in terms of functioning. So we do a lot of things like setting reminders and alarms and whiteboards and lots of things that they can structure their lives around, and so they're not forgetting appointments, and so they're not forgetting things, and these are the little things that they may already have in their life. And just also looking around sleep, because you mentioned clonidine, and in Australia we don't have the long-acting version, which can be used for ADHD. We have only got the immediate version, and we use that sometimes for sleep. So when you've got your stimulant throughout the day or your non-stimulant, you can use that clonidine at night for sleep. So I use that a lot in my practice.
Yeah, fascinating. Okay, I'm sorry we've had to rush that section because it's very important. But anyway, I think we've alluded to it all the way through the various components and very valuable. As we come towards the end, I'd like to talk a bit about outcomes, outcomes and next steps. But let's say we've now been seeing Tanya for a little while. She's got this top-class multidisciplinary team working with her, which she's very fortunate to have. I'm not suggesting that everybody would have that, but she's got it. What do you think would be a good outcome in this case? What could we reasonably expect as being the best possible outcome for someone like Tanya? And I'm happy for you to just kind of free associate, but I've got some questions, and perhaps we start. No, you free associate. What do you think would be a good outcome for her?
So, imagine that, me stepping in and talking first. For me, it'd be like, is she reaching her function goals? So, is she sleeping well? Is she feeling better within herself, her confidence, being able to do the work that she wants to do? Working on the relationship with her husband, her children, her parenting, skills as well. So it's really, from my perspective, all about her function and how well she's feeling, she's functioning, and how balanced her symptoms feel for her. So that's what I'd be looking for and working towards.
Yeah, and quite rightly, I know you'll say in answer to my question, well, it depends what she wants. But how important is it for her to get back to her work? Her work is pretty important to her. Are we going to put a high priority on that, do you think?
It's funny because I've got my psychotherapist hat on, and it's like, but is it important to her, or was it important to her? So is it important to her now? And, was that something she was doing because she had to prove herself, because she never felt good enough, because she had ADHD and had to work so hard? But now she knows she's got ADHD. She can go, I don't like that. This is okay, and this is enough. So maybe her values of worth and success might have altered a little bit.
Okay, would others like to jump in on what you would see as a good outcome? When would you say to yourself, oh, I did a good job with her? Jag.
So I just reinforce what Naomi is saying. So two things. One is it's individually driven. And so when I say individually driven, career is important. If Tanya believes that getting back to work gives her that sense of identity and sense of being in control, we certainly need to work towards that. And lack of control is one of the reasons why she has presented in the way what we are talking about. And so second thing is that she needs to have that subjective satisfaction, because there are issues happening at home that needs to be addressed enough as well. So we need to focus on that, and so that it can fulfill her role as a parent. Otherwise, there is a likelihood self-esteem can go down and it leads to more frictions at home. In a medical sense, there is a symptom remission. Some people prefer symptom remission, and rather than just a partial improvement. Some people don't like symptom remission. I've seen, not some people, very few. They want to be left alone to be themselves. They don't like to have a streamlined, single thought approach. They want to have a free-flowing, creative mindset. So it varies. And what I have seen is that sometimes once they have an experience of a medication, if it clicks for them, when they say how the mind is different, then they decide often whether they like to pursue that. I have seen, for example, similar case, a project manager, 55-year-old male comes along, wants to be assessed because he has been dealing with anxiety, but very highly functioning project manager. With a thorough assessment, confirmed that there's ADHD, he wanted to try the medication. We went on with one of the stimulants. Within a couple of weeks, he says, I don't need to organize myself to that detail anymore. I have so much of a free space in my head. So it can be relieving in medicine. So it depends on what individuals want to focus on.
Yeah, quite. Emma or Amanda, what would be your good outcomes? What would you say we can achieve with Tanya?
To you, Amanda.
I think family functioning, having that cohesive family. So at some point we would have involved maybe a family therapist in one of our multidisciplinary team meetings, and had a look at, if Greg is the primary carer at home, why did that occur? And so, maybe Tanya wants to do that now. And I guess that success would be around what she really wants and whether she's met that. But definitely involving that family in her goals and in her functioning.
And the point that you've just made, and indeed many of you have made, or implicitly, is that, and we see it, don't we, in mental health all the time, that if the identified patient manages to change and get better or change or whatever, that changes the whole dynamic at home. And suddenly, whoa, everything's very different. And so I think you're right. We really need to be aware of those possibly changed dynamics. Emma, do you want to say anything? Do you want to add anything in terms of outcomes?
Yeah, I'm obviously loving what the MDT has already said around, really exploring her choices of the work that she was doing. Was that overcompensation? Was that her struggling with this, the sense of being different, of having this different neurotype, of being ADHD? And is that something that she wants to return to? And I think my goals would be reflective of her goals, obviously, but I would be looking perhaps for a sense of greater self-advocacy, that she can speak up, she can actually ask for accommodations if that's what she needs for at work, she can actually ask for medications to be adjusted if she feels that that's impacted on her relationship at all, and a sense of self-determination. So rather than masking through overcompensation and overachievement, what actually does she really want to do? And is she happy?
And of course, this is an impossible question, but that doesn't stop me asking it. One of the dilemmas we often have, I think, is when is enough? When have we given her as much as we can reasonably do? And if you look at the graph of how people improve in treatment, generally speaking, we get this big, steep improvement, and it gradually flattens off. And it comes a point where continuing to see the client is actually not terribly sensible. I'm not expecting any magic answers, but does anyone want to just say anything about that? When do we stop?
Well, I actually was writing this in a report today. Mental health and these sorts of issues, it's not a broken leg. It's not excellent, they're fixed. It's quite likely that they will need ongoing, monthly or bi-monthly or 3-monthly, however long that it stretches out, sort of check-ins. And it's almost, I look at it like almost a supervision or a reflection time where they can go, okay, it's just a checkpoint. How are we going? How are our symptoms? Let's see where things are going. Do we need to do anything. And so it's actually a preventative thing ongoing to make, prevent any deterioration of symptoms, to make sure that they maintain as healthy a balance as possible. So, it doesn't mean they need to see all of everybody in the multidisciplinary team, but I think that it's really important that people have, whether it's the GP or the nurse practitioner or the OT, the ADHD coach, whoever it is, that they have that check-in point ongoing.
And that if they need to, then if the wheels are starting to come off, you can get in quickly and you can bring our magnificent team back together to help her through. Okay. We could easily go on for another hour, and I have got through most of the questions on my list, not all, but anyway, have to be realistic. But we could go on for ages. I found it a fascinating discussion. I must say that I've learned a huge amount, and I'm sure our participants have as well. But we do have to move towards winding up. Just before we wind up, I would like to give our panelists the opportunity to say a few final words. Any reflections on this process, anything that we missed that we should have talked about, any take-home messages for our participants, and perhaps we'll go through it in the same order we've been going through. So Naomi, if it's okay with you, any final closing comments from you?
So first thing is just to bring up the point, she's 45, think perimenopause as well, because it actually exacerbates ADHD symptoms. So, if she can, and if it's, side effects and allow and that sort of stuff, consider some menopausal hormone therapy as well. In regards to if anybody who's got ADHD or thinks they've got ADHD, but then for those who don't have ADHD, just to have a bit of self-compassion and also just understanding. And it's really about, one of the biggest things for myself was I was able to just stop asking myself to do something that physiologically I can't do. So just have that self-compassion, that self-understanding. It's not because you're not trying hard enough or you're not smart enough. It's you can't physiologically do it. So
okay, thanks, Naomi. Some very brief. I'm going to make you talk less than Naomi. Some very brief comments, Amanda.
Yeah, I completely agree with Naomi. The one thing that I would have also looked at is cognitive disengagement syndrome, or sluggish cognitive tempo, which can be misdiagnosed as inattentive ADHD without the hyperactivity. So that's a very common one that I see in my current practice. That's my last comment.
Excellent. Okay, thank you very much. Jag, any closing comments you'd like to leave our participants with?
I think it's already been Naomi and Amanda has mentioned. So I think it's important to have a very holistic approach because there are a lot of the clinics are being flooded with the need for assessment. I also hear that there is a reluctance growing up on the other side not to engage with any clients asking for assessment. So I think we need to be compassionate, at the same time be holistic, so that we provide a thorough assessment. If it leads to ADHD, then we talk about ADHD. And what also we need to realize, there is the power with the psychoeducation. It's underutilized tool. Often that's enough for people to just carry on with the line once they understand what it is. So it doesn't need to be medication, specific interventions for a lot of people. So that's what I mean.
Very good point. And we shouldn't dismiss those apparently simple kind of things that we can do that can be very valuable. Emma, a closing comment.
Yeah, I think this just draws the line again under how important it is to understand the difference between something that might be depression or might be more of a neurodifference burnout. And obviously there's very different approaches with burnout. It is actually to ease off with that sense of self-compassion. And Tanya is so common to the health professionals and executives that I actually see in coaching, where people push themselves to the limit and then they just can't do it. So if you've met one person with ADHD, you've only met one person. The value of context is so important. And I think one of the key messages of whether I'm working as a therapist or in my ADHD coaching role is just to explain through psychoeducation that this isn't a moral failing of this client. They've not done anything wrong. In fact, if anything, they've overachieved, because neurodivergency is usually a situation where you're dealing with so much more, but seen to be doing less somehow. that I think the biggest thing we can do as compassionate caring professionals is just to express, that this is not a moral failing, this is just brain wiring.
An important message to end on, Emma. Important. Thank you so much to all of you. That's been absolutely wonderful. And to our participants, if you'd like to know any more about Naomi, Amanda, Jag, or Emma, go to the landing page for this episode on the MHPN website. You'll also find a feedback survey there, and it's very short, and we really would encourage you, if you could, to fill in the feedback survey. Tell us what you thought about tonight and the format and so on, but also tell us a bit about what you think MHPN can do for you to meet your needs. You're going to receive a certificate of attendance in the coming days. But for now, it's goodbye. Thank you very much again to our panelists, Naomi, Amanda, Jag, and Emma. And thank you all to our participants for being with us tonight. I hope you enjoyed it as much as we have. And please keep an eye out for future webinars from MHPN. I saw that there's one coming up on infant mental health, which is a fascinating topic, and I think I'll come along to that one, and another one working on addiction. So there's lots of stuff happening. Keep an eye on the MHPN website. But in the meantime, thank you very much again to our panelists and to you, our participants. Thanks again, and bye for now. Bye.